Okay, thank you so much. Good evening, Shubh Sandhya, to all the members. Respected Jayanta Burwa, sir, our Vice President, and Swaraj Bhattacharya, who was here, Chairman ARC, the Speaker, Dr. Manish Singh, Moderator and Panelist, and my dear delegates who are there in this platform. So today we are here with our second ARC webinar, and this is an initiative of EIZOC, a digital platform where we discuss common topics of ophthalmology. So today we have one very important topic, that is the basics of glaucoma diagnosis. Because this is glaucoma, I think, is a very underdiagnosed entity in our ophthalmology, and this would be very, very beneficial for our, especially for our general ophthalmologists. So I think this webinar would be of immense help to all the practicing upcoming general ophthalmologists, and also those who are in the various subspecialties. So I'd like to then hand over the mic to our Vice President, Jayanta Burwa, sir.
Good evening, everybody. I welcome. It's okay. I welcome you all to this very, very important and interesting seminar today, webinar, on glaucoma basics. See, this is a very practical problem that we find glaucoma cases in a very advanced stages because we miss them at the outset. And if you don't diagnose a case glaucoma early, the damage is already done. So this is important right from the history, measurement of IOP, including diurnal IOP, then gonioscopy, slit lamp examination, optic nerve head study, perimetry, OCT, and a lot of things. And today we have a very good speaker in Dr. Manish Singh, and I'd like to appreciate Dr. Sangsui for his good work. I hand over the mic to the Chairman Scientifically for the contribution of the meeting.
Thank you, sir, and good evening to you all. I'd like to introduce our moderator of today's webinar, Dr. Ajit Kumar Dwivedi. And we have a very good speaker in Dr. Manish. He has kindly agreed. So I'll just give an introduction of Dr. Dwivedi, who has done his MBBS in 2003 from Nalanda Medical College, Patna. He has finished his MS Ophthalmology from Darbhanga Medical College in the year 2007. And he did his fellowship in glaucoma from Arabian Eye Hospital, Tirunelveli, completed in the year 2009. He has areas of interest in glaucoma, cataract, and refractive surgery. He has worked in various private hospitals, including Lumbini Eye Institute in Nepal and Vasan Eye Care, Patna. And he is the founder director of Sarda Eye Hospital in Palmer. Currently, he is posted as Bhimhas, Koilwar, and deputed at Rajendra Nagar Super Specialty Eye Hospital as Specialist Medical Officer. He has various publications at the national and international journals, including ACTA Scientific Ophthalmology. He has various presentations, scientific presentations at the state and national and international conferences, including GSI, SARC, and APAO. He has been the editor of the Patna Ophthalmological Society from 2021 to 2024. He has been the Bihar State nominee of LDP batch 2022 to 23 at the AIOS. He has been the organizing secretary of PostCon 2022. He has also been an executive council member of AIOS midterm conference held in Patna in 2022. He has represented Bihar in AIOS GSI and EIZOC conferences, and he has represented also Nepal in the SAC conference. So, gentlemen, I give over the hand over the proceedings to Dr. Dwivedi. Dr. Dwivedi, please.
And first of all, very grateful for such a brief and detailed, I will say not brief, detailed introduction to the EIZOC for this one. And what a basic topic. And we have a great panel with us, and our own speaker, I can say, our own speaker, very known to us. I will introduce him in due course. So first to know about our panel here, and I feel indebted to the EIZOC for giving me this session moderation, for choosing me for that. So first of all, for Dr. Nitin Dhara, and he did his in DNB from, he's one of our panelists today. He did his DNB from LV Prasad, Hyderabad, and he works at a part-time consultant at Jamshed's own complete setup at Sarda, FACO and cases, premium cases, and as well as the complicated one. And he has a keen interest in glaucoma and horizontal squint, and even medical retina too. And coming to the our next panelist, Dr. Sumit Mahapatra. She completed her MS ophthalmology in 1987, joined medical college, and did her glaucoma fellowship from a great reputed institute, PGI Chandigarh, and she had a teaching experience of 27 years, 12 years as professor. I can say the career which we have is just as a professor ma'am had. And she is the head of glaucoma clinic since 17 years, seeing a lot of, her experience will be surmountable to all of us, will be beneficial. She has been the chief instructor in many instruction courses in AIS conferences, faculty in PG refresher courses, which are very popular nowadays. And she has conducted Glaucoma India Education Program of Glaucoma Society of India, and has several publications in indexed and peer-reviewed journals. Welcome, ma'am, to the board, and we are really enriched with your presence here. And now I want to introduce Dr. Sainur Tayyab, who doesn't need any introduction, I think. With in such a great time, she did the MBBS from Rajiv Gandhi University of Health Sciences, Bangalore, and from MS from Guwahati Medical College and Hospital, Guwahati itself. And she was trained from Shankar Nethralaya in 2007 to 2009 in a fellowship for glaucoma. And since then, he is in Shankar Dev Nethralaya, which is well known for the glaucoma care in that region and creating benchmark. And I have seen so many times her presentations made at in GSI, and she has a poster presentation in World Glaucoma Congress and at Rome, and as well as the Melbourne. And many presentations were made basically on a perimetry we revisited in glaucoma, which is very keen on the topic itself in OSACon 2012, and we on equine in visual field analysis in 2011 itself. And there are many presentations to in his record, and we are really very much increased. He has many publications as well on a case report published in Tamil Nadu Journal of Ophthalmology, and we will be really blessed with expert comment and things from on this basics of glaucoma. So really, and I will say the topic chosen, the basics of glaucoma. It's a basically first step where we all have to learn. And we all still are learning on as far as the glaucoma is concerned. And we need to learn how to go to the society, how to find more and more of them. And Dr. Manish Singh has so much experience, basically, and so much uh, still in so many years, there'll be most of the glaucoma persons become a little bit irritated, but he is so attractive and a very favorite among many of us with his talks and everything. And I will just like to have a introduction before he starts on the topic itself. And a small introduction. He has completed MS in ophthalmology from the RIO Kolkata itself, and with the university gold medal. And he did his long-term fellowship in glaucoma at Sankara Nethralaya, Chennai. And there he was a consultant too, and he has received Best Consultant Award in Sankara Nethralaya in 2011 and 12. Currently, he is working as a senior consultant and executive director, Netralayam, the super specialty eye care center, Kolkata. He received the multiple awards, including the best poster at the Regional Ophthalmological Congress at Kuala Lumpur in 2009. He has received Best Poster Award at Ophthalmological Society of West Bengal Annual Conference 2015, and he has been the Eastern General Representative of Glaucoma Society as well as the Joint Treasurer of the GSI. Currently, he is the Honorary Treasurer of the Glaucoma Society of India. He has published 22 articles in peer-reviewed national and international journals and made more than 200 presentations at state, national, and international meets. He has been the chief instructor for glaucoma at the state conference since 2010 and an instructor for Glaucoma Society of India annual conference since 2011. He received the B.N. Gupta Oration and Award from Equine in 2018 and has published 3 books in ophthalmology and written 10 chapters. What a deep understanding. And over and above, I can say each time when you listen him, you will learn a new thing. I can tell you, even after so much presentation, so much presence in our part, I think the whole of the EIZOC will agree with me. So please welcome Dr. Manish Singh for basics of glaucoma. We want to learn from you. And there are other panels sitting regarding the residents are there. They want to ask you some questions. They want to learn from you, and we will also learn you. Please welcome Dr. Manish Singh.
Thank you, Dr. Ajit, for being so generous with all the introductions, and it's a great honor to be here. Thanks to Professor Chingshui sir for inviting me, and nice meeting Ajit, Dr. Ajit, and we have been collaborating in a lot of academic work. In fact, we're also working on currently a book with Dr. Ajit, and Shainur is a very good friend since 2007. We keep on collaborating for multiple things. Sumita madam has been so encouraging all the time, and Pranava's son is there. So most important thing today, what Professor Chingshui sir has told me, that I should make a presentation which is basic, mainly for the residents and for the comprehensive ophthalmology. So it's a presentation which will be focusing on how to evaluate glaucoma in your day-to-day OPD. Not much of instrument, more of how to evolve your clinical acumen to diagnose glaucoma. So I'll just share my slide. Is it visible, Dr. Ajit?
Yes.
Yes,
So
we can see
this
nice.
is the basics of glaucoma diagnosis. And we have an esteemed panel. So if any resident has any question, I'm sure we all will like to answer them. So topic is basics of glaucoma diagnosis. I'll just share a few concepts about overall diagnosis in glaucoma. You know, when you're practicing glaucoma in your OPD, a lot of time you will see patient will come and ask you one very common question, that can you prevent glaucoma? And especially like today I had a lady whose mother is having glaucoma, whose sister is having glaucoma. She's extremely scared, extremely worried. She wants that if some way we can prevent glaucoma. Unfortunately, we cannot prevent glaucoma, But what we can do is that we can prevent blindness from glaucoma. And the whole idea why we are meeting today in a webinar like this, spending our valuable time together, is that we want to discuss how we can diagnose glaucoma early so that we can prevent the progression of glaucoma and we can prevent the blindness of glaucoma. So whole idea of glaucoma treatment is first the early diagnosis. The earlier you diagnose glaucoma, it is better for you, because then you have more nerve to save. And for that, it is very important that we should have a comprehensive eye evaluation of every patient who walks into your OPD. So patient will come to you for cataract surgery, patient will come to you for itching, patient will come to you for floaters. It is our duty to make sure that every patient who comes to our OPD, we check the vision, we check the pressure, look into the angle, see the disc, and we don't miss silent diseases like glaucoma. Even so many silent retinal diseases are also detected if you have a comprehensive evaluation of every patient who walks into your OPD. This is the ideal time to diagnose glaucoma when your damage is early. Most of the nerve is still there to be saved. Diagnosing glaucoma in a stage like this, where most of the nerve is already damaged, is not difficult and not very satisfying also, because these patients will have very advanced field loss. It will be difficult for you also to manage these patients. Also, one important thought I like to share with the resident, when we start practicing glaucoma, we always have this habit to write the medication. Suppose the patient pressure is 24, you want to start a prostaglandin or you want to start timolol. Before you start the treatment, always write the diagnosis. Say primary open angle glaucoma or primary angle closure glaucoma, secondary glaucoma, whatever is the diagnosis. You make sure that unless you have written the diagnosis, you will not start the treatment. It's a very good habit, When you write a diagnosis of, say, primary open angle glaucoma, it makes you think, have I done a gonioscopy? When you write a diagnosis of, say, secondary glaucoma, it makes you think, have I taken the history of steroid? Have I looked for angle recession? Have I seen the pigment dispersion or pseudoexfoliation? When you write the diagnosis of glaucoma, it makes you think beyond intraocular pressure. Or else what happens in the busy OPD, you are actually treating intraocular pressure only. Pressure is 24, you add medicine. Pressure is 18, you are satisfied. So you are basically treating the IOP and not the disease as a whole. But when you write the diagnosis, it makes you think in a broader perspective. I'll share 2-3 very basic cases which you will see every day in your OPD, and just like to share how we can approach these cases so that we give the best treatment to our patient. This is a gentleman, a 36-year-old gentleman, comes for routine evaluation in your OPD. No family history of glaucoma, vision is normal, pressure is 24 millimeter mercury, angles are open on gonioscopy. The disc you can see right eye maybe around 0.6, healthy. The red fee photograph also is showing no RNFL defect. Other eye also is healthy, a little bit of superior slope, but 0.7 or 0.6 to 0.7 is a healthy disc. Visual field also is normal. So what is the diagnosis? So you have a patient comes to your OPD, everything is normal, just the pressure is high. Should we treat this patient? Now this is a very common case we face in our OPD. And do we need to further investigate? I think it's not possible to interact in this session, so I'll just move to the next slide. Very important thing, if you realize in this patient, central corneal thickness was not checked. Suppose you check the central corneal thickness and the central corneal thickness is, say, 620 micron. The corrected pressure will be something around 16 to 18 millimeter mercury. There are no universally accepted correction factor, but roughly you can say 7 millimeter is equal to 100 micron. Sometimes we say 15 micron is equal to 1 millimeter. So there are multiple correction factors. The basic idea is in thicker cornea, you have higher pressure. In thinner cornea, you tend to have a underestimation. So suppose the CCT is 420, your actual pressure will be around, say, 30 to 32 millimeter mercury. In my practice, if I have a patient with pressure of 70 and the rest everything is normal, why will I treat this patient? This is not even an ocular hypertension. If suppose the pressure is, CCT is 420 and the corrected pressure is 31, I'll probably not leave the patient, because as per the ocular hypertension treatment study, if your corrected pressure is more than 26, you should not leave the patient. So what I'm trying to highlight here is that just a central corneal thickness can change your perception of intraocular pressure. So it's very important you always check central corneal thickness in your glaucoma patient. Today only I saw a patient seen by a very reputed institute in East India, where the patient is a cardiologist, pressure was 23-24 millimeter mercury, and the patient's CCT was not done. Patient had a OCT done, patient has an entry segment OCT done, HVF done, but this photograph done, but CCT was not done, and patient was started on medication. When we did the CCT, pressure, baseline pressure was 23-24 millimeter mercury. We did the CCT today, it came to 590 micron. So if you have a 590 micron with a 23-24 millimeter pressure, this is not ocular hypertension, this is normal patient. So unless you check central corneal thickness, you will not understand what is the correct or corrected intraocular pressure. So very, very important, have a comprehensive evaluation of your patient before you start treatment on glaucoma. A lot of time there is an impulse on this to start the treatment. Have a comprehensive evaluation, make sure you have checked all the basics, and then you treat your patient. Also very important thing, we have so many times you will see company people coming and telling you that I've got this tonometer, new tonometers, then the tonopen is there, then we have I think a lot of people are now using eye care, rebound tonometer. But even now, the best tonometer, in spite of all its fallacies, is the Goldman application tonometer. So if you are doing a serious glaucoma patient, please treat your patient using a Goldman application tonometer. Don't treat a patient using a rebound tonometer or a non-contact tonometer. It will not be acceptable from a glaucoma point of view. So first case, I wanted to basically highlight about the role of central corneal thickness, which is something often missed in practice, but we should try to incorporate for every glaucoma patient. Now, this is a pseudophakic glaucoma patient. This is a patient who underwent cataract surgery somewhere in Maharashtra. And patient was having gradual decrease in vision with floaters and glare. Patient was already on glaucoma medication. He was treated on and off with steroid. When the patient came to us, this was the picture. The eye was congested. You can see some keratic precipitate. So basically there was some inflammation. The IOL was in sulcus, but it was a rigid IOL. There was diffuse corneal edema. So basically it was an inflamed eye, and the pressure was 32 millimeter mercury. Here the CCT is high, but this CCT you don't need to correct because this patient is having corneal edema. These correction factors are applicable for normal corneas. If you have abnormal cornea like a corneal edema or patient with corneal dystrophy, these cases you should not use those correction factors. In fact, in corneal edema, you tend to have underestimation. So if the pressure is 32, your actual pressure probably will be 34 or 35 millimeter mercury. The disc was healthy, patient had a CME. So in this case, what is our diagnosis? So if you see the clinical impression, what appears like the patient had a cataract surgery. There was some problem with cataract surgery. The lens was put in the sulcus, and patient had a chronic inflammation for which steroid was given, and patient developed glaucoma. Now, glaucoma can be because of the uveitis. The glaucoma can be because of the steroid also. But one very important thing which was missed in this case, again, I was telling you, always have a complete evaluation before you treat this patient. So last case we discussed about IOP, this case gonioscopy. This patient was undergoing treatment for glaucoma for 6 months, but gonioscopy was never performed. If you had read Professor Ravi Thomas' article on glaucoma in India, he had very nicely highlighted that in India, more than 50% glaucoma patients are still treated without gonioscopy. And this is a very basic test which can be done in any setup in India. You just need a gonioscope, and nowadays so many Indian companies, they make gonioscope which is say 4,000 or 5,000 rupees. So there's no reason for not doing a gonioscope. In this case, when we did a gonioscopy, we found that there was a misplaced capsule tension ring in the angle. So what might have, you can see the eyelet of the CTR here. So what might have happened during cataract surgery, maybe the patient was uncooperative, surgeon was not comfortable, he was trying to put a CTR, CTR went into the angle, he somehow was able to put the lens in the sulcus. Now, post-operatively, patient had inflammation, he was given steroid, but the inflammation was also because of this CTR. Every time this iris is rubbing with the CTR, it is causing more and more inflammation. So diagnosis is the same. It is a secondary glaucoma. But what is the cause of secondary glaucoma? The cause is this CTR. The cause is this chronic uveitis and also steroid. So we've removed this CTR. The CTR removal was done. We don't need to go into details of how it was removed. And then the inflammation came down. We were able to control this with 2 medications. Since it's an inflamed eye, you should avoid pilocarpine, you should avoid prostaglandin. But you can use a timolol, you can use a brimonidine, you can use a dorzolamide, brinzolamide, even the ROCK inhibitors. So just the gonioscopy helped us understand the mechanism of glaucoma. So gonioscopy should be an integral part of every glaucoma patient. So let me put in a more different way. Who needs gonioscopy? Ideally, every patient deserves a gonioscopy. In case you're not able to do in every patient, you can do Von Herrick. See those patients who have shallow chamber, there you should do gonioscopy. But if you're treating glaucoma, every patient deserves a gonioscopy. It is their right to have a gonioscopy. If you're treating glaucoma patient without gonioscopy, you can end up in a serious medical legal problem. Suppose I'm treating a glaucoma patient, I'm assuming the angle is open without doing gonioscopy, maybe just based on a EIZOC or a Von Herrick's, and I'm treating the patient. Patient goes to Dr. Shahinur. She sees the angle is closed and she advises a PI. Patient, if suppose files a case against me that because the gonioscopy was not done, the disease progressed, how I am going to defend myself that why I didn't do gonioscopy? Today's patient which I was telling you, which came to my OP today, a cardiologist seen by a reputed center, CCT was not done. That patient was advised a PI based on anterior segment OCT, but a gonioscopy was not done. So if you have an anterior segment OCT, you obviously have the infrastructure for gonioscopy also. Again, like Goldman apprenation tonometer is the gold standard for apprenation IOP checkup. Gonioscopy using a 4-mirror, if not 4-mirror, maybe 1-mirror, 2-mirror is the gold standard. If you have a patient where you're seeing on EIZOC angle is closed and on gonioscopy angle is open, or else on gonioscopy angle is closed and EIZOC angle is borderline, you should go with the gonioscopy and not the EIZOC, because in gonioscopy you are actually seeing the trabecular meshwork. You are seeing those patchy pigmentation. You are seeing those synechias which you cannot see with anterior segment OCT. So gonioscopy is still the gold standard for angle evaluation in a glaucoma patient. Every glaucoma patient deserves a gonioscopy. Also indicated for every patient with family history of glaucoma, patient with raised IOP, trauma, pigment dispersion, pseudoexfoliation, patient with retinal vein occlusion. If you see glaucoma in Indian perspective, 1/5 of the world glaucoma patients are in India. And there's nothing to be proud of. Like, we have a huge load of glaucoma in our system, and we need to have the infrastructure to manage it. But whatever we have read in Kansky or other textbook, the open angle glaucoma is more common in Western population. But in Indian population, Chinese population, the angle closure glaucoma is equal to open angle glaucoma, if not more. In Indian population, in fact, it is 1:1 ratio of open and angle closure glaucoma. What it means that gonioscopy is even more important for our population compared to the Western population. Also, the risk of blindness is 2 times higher in angle closure glaucoma compared to open angle glaucoma. Also, we were discussing in the start whether glaucoma is preventable or not. Open angle glaucoma you cannot prevent because patients are genetically predisposed to open angle glaucoma for juvenile glaucoma. But you can prevent an angle closure glaucoma. If you're doing timely gonioscopy, if you detect occludable angle, if you see those early synechia, you do a timely PI, a large majority of these patients will never develop glaucoma. So in a way, you are actually preventing glaucoma by doing a simple, timely gonioscopy. But the question is, why gonioscopy is still not popular? Why most, or say a large number of glaucoma in India is treated without gonioscopy? There are multiple reasons. One important thing is the lack of training. Maybe somewhere on our part, we haven't trained our resident properly in gonioscopy. They still I know a lot of retina surgeons, they come and tell me gonioscopy is so difficult. They are doing indirect, they are seeing those auras, they are doing laser, but they can't do gonioscopy. It's not possible. Maybe we are not giving gonioscopy adequate importance. Multiple reasons why gonioscopy has not become popular. One, because we have, like personally, I was trained with the 1 mirror, 2 mirror gonoscope, and this is a little cumbersome process. You have to put a topical anesthesia, put the gel on the lens, then put the lens. So whole thing takes time. So in a busy OPD, sometimes you sort of try to avoid doing gonioscopy. But when I switch to a 4 mirror gonoscope like a Postner or a Sussman type or a Zeiss type, whatever you're using, the lenses are flatter than the corneal curvature. So you don't need a coupling gel. Once you have checked applanation torometry, you have checked the pressure, eye is already anesthetized, you can just simply put the lens and see the angle. So since you're not using coupling gel, it is very quick, comfortable, and at the same time, you can differentiate a cynical and an appositional closure, which is difficult to do with a 1 mirror or 2 mirror gonoscope. So suppose this is a closed angle or 1 mirror, 2 mirror. When you compress and the angle opens up, this means this is a cynical closure. On the other hand, when you compress, so this is a appositional closure, sorry. On the other hand, when you compress these early synecia, this means the cynical closure has started. So in a patient like this, where you have just appositional closure and there are no other risk factor, you can just keep the patient under follow-up. On the other hand, when the synecia has started to form, this means the patient has moved from occludable angle to angle closure stage. In these patients like these, you have to do iridotomy. Or simple gonoscopy and indentation gonoscopy can tell you very clearly which patient needs iridotomy, which patient doesn't need iridotomy. I'll share a small video. See, the whole process of applanation tonometry and a gonoscopy can actually be done in a minute. We have already put topical anesthesia and a fluorescent strip. We are checking the pressure in one eye, then checking the pressure in other eye. Then using the 4 mirror gonoscope, you can just simply put it over the cornea. And you can just reduce the illumination of the room. Just keep it a dim light. If it is a very brightly illuminated room, it will cause miosis. And keep the light 2 by 2 millimeters so that it falls directly on the angle, doesn't fall on the pupil. So you can see, since it's a 4 mirror, you don't even need to rotate, just up, down, right, and left. So the whole process of applanation tonometry and gonoscopy can be done in just a 1 minute time. So once you switch to a 4 mirror gonoscope, you will realize you will be doing many more gonoscopy compared to 1 mirror or 2 mirror. I'll share a few small videos like this. Is having a right illumination is very important. When the illumination is low, light is falling on the angle, you can see the angle is closed. But when you increase the illumination, you see the angle is appearing to be open. So always have the correct illumination. Keep the illumination 2 by 2 millimeter or whatever size which is comfortable, but the light should fall only on the angle and not on the pupil, because that will lead to falsely opening of the angle. Initially, when you start using 4 mirror, you will have some problem with fixation. Ask the patient to look centrally. If you see something is entering from the light, this means the air is entering. Ask the patient to look centrally. Keep the lens in the center, and slowly, with time, after doing 15-20 gonoscopy, you will become comfortable with this positioning and centration. Glaring can be a problem at times, so never use illumination directly over the angle. Always try to use the oblique illumination so that you have less glare and you can directly and properly visualize these angle structures. Again, when you're doing gonoscopy, sometimes initially you always have the tendency to put a little extra pressure because the eye is not fixated in a 4 mirror gonoscope like what we have in a 1 mirror or 2 mirror gonoscope. So the eye is constantly moving, and we tend to put little pressure on the cornea so that to ensure that the eye doesn't move. This can lead to folds like these. So if you have a fold like this, just move back a bit, because these folds indicate that you are putting extra pressure, and that can lead to falsely opening of the angle. Again, why 4 mirror is so important and why indentation is important. In a normal 1 mirror, 2 mirror, this is the Solby's line which appear as a trabecular meshwork. So this angle you will see and you will think it's a open angle. But when you indent, you will see actual trabecular meshwork was hidden behind the iris. And what was appearing as the trabecular meshwork was actually a pigmented Solby's line. in our Indian eyes, we have a lot of patients who have pigmented solvage line, especially inferior pigmentation. These can often be mistaken for a open angle, which are actually a closed angle. I'm not going to details of this structure. These are available in all the books. But this is example of a pigmented solvage line and a pigmented trabecular meshwork. Trabecular meshwork has a more uniform pigmentation. Solvage line has more little patchy pigmentation, but sometimes it can be very confusing. And for that, it's important to use a indentation gonioscopy. So we're talking about the second important thing as we are discussing about the basics of, we discussed about applanation, we discussed about CCT, we are discussing about gonioscopy. So IOP is important for treating glaucoma patient. Pressure is high or low, whether it's you need to bring down the pressure, what should be the target pressure. So when you're treating glaucoma patient, it is very important to know what is the baseline intraocular pressure or what is the pressure of the patient. CCT is important to understand what is the ideal pressure for that particular patient, whether the pressure is overestimating or underestimating, and how we can get the correct pressure. But gonioscopy is something where we can differentiate an open angle from a closed angle. Plus, by looking at the gonioscope, we can also understand the mechanism and the pathogenesis of glaucoma. For example, this is a case where you can see multiple point synechia with a patchy pigmentation of trabecular meshwork, which is typically seen in an angle closure glaucoma, primary angle closure glaucoma. This is another patient. You can see these. Dr. Ajit, can you see the arrow? Can you see the pointer?
Yeah.
Yes.
So in this case, you can see these are broad synechias which are well anterior to the solvage line. So sometimes when you have acute uveitis and inflammation, the iris will go and stuck with the periphery of the cornea. So this can lead to these broad synechias. This is a uveitic glaucoma. This is another patient where you can see a broad synechia here, but rest of the angle is open. So they are localized synechia, what we typically see in eye syndromes. And this is another patient where you have multiple synechia looking thing, which are basically iris strands, and they are extending well into the solvage line, and solvage line is also quite anterior. Plus, you can see these holes in the iris. So these are basically axon field rigor anomaly. So sometimes looking at the gonioscope, apart from open and closed angle, also angle recession, pigment dispersion, pseudoexfoliation, so many diseases you can actually diagnose and understand the mechanism of glaucoma by looking at the gonioscope. So third important point in the basics of glaucoma diagnosis is the disc evaluation. So we'll talk about the disc evaluation. So this is a patient who again came for second opinion. Patient was suspected as glaucoma elsewhere. So suppose patient went to Dr. Ajit. Dr. Ajit told him that you are having glaucoma. He went to Pranav Ranjan sir for second opinion. The glaucoma patient, a lot of the time they go for second opinion because these patients are asymptomatic patients. They don't have actually any problem. So when you suddenly tell them you are having glaucoma, so it's like a shock for them. So because they are not mentally prepared. Yeah, we have to suddenly it's not a very pleasant diagnosis that you are having glaucoma. So when you have this type of diagnosis, patient will try to take second opinion, third opinion. So these type of patients are very common. This patient had a pressure of 19 millimeter mercury. The CCT was normal, rather on the higher side, wide open angle. So all these parameters were fine. If you see the disc, looks like around 0.7. Left eye also around 0.7. The left eye cupping is slightly more than the right eye, but the disc is also slightly bigger in the left eye. So we have seen the larger discs tend to have larger cups. So this type of asymmetry can also be because of the difference in the size of the disc. But if you see the perimetry, there is superior and nasal field defect in right eye, superior inferior field defect in left eye. So the patient basically wants to know whether I am having glaucoma or not. And this is a common question you will face once you start practicing. The residents, when they start practicing, patient will come with a perimetry report, patient will come with an OCT report, and patient will ask you a direct question. Glaucoma hai ki nahi? No goal, no, you can't have a like suspect and all. You have to tell them sometime very direct question. Also, I tell you something, sometimes patient will send you a WhatsApp. This is my perimetry report. Do I have glaucoma or not? Or this is my OCT report. Do I have glaucoma or not? Never comment on those things. Always tell them glaucoma is a diagnosis based on evaluation of the patient. I need to see the pressure. I need to see the pressure. I need to see the angle. I need to see the disc. then only I can comment on glaucoma. I'm not that big a doctor that just by looking at the perimetry or OCT, I can diagnose glaucoma. So never make a comment, always ask the patient to come. Now in this particular patient, looking at this patient was started on anti-glaucoma medication. But when we saw the patient, what is very, very important thing in glaucoma is the disc evaluation. See, glaucoma is a disease of optic nerve. Glaucoma is a chronic optic neuropathy with classical disc and field changes. This is the definition of glaucoma. The pressure is not a part of glaucoma definition, and gonioscopy is also not a part of glaucoma definition. So diagnosis of glaucoma basically is based on classic disc changes with a corresponding field defect. If you see the disc in the right eye, it is following the isn't rule. That is, the inferior rim is thickest, followed by superior, then nasal, and the temporal. Plus, if you see, the RNFL looks to be okay. The cup is slightly large, but the neuroretinal rim, which is more important, is perfectly healthy. If you have a field like this, where you have a superior defect and nasal defect, you should have some inferior thinning here, which is not there. So the disc is not matching with the fields. And as I'm telling you, glaucoma is a diagnosis based on the disc evaluation. How well you can evaluate the disc, how confident you are about your disc finding decides how good a glaucoma expert you are. You should not be biased based on the perimetry. If I am sure about my disc finding, I tell my patient that this is an artifact. There is a problem with the perimetry, not with my disc evaluation. Similarly, if you see the other eye, yes, it is slightly bigger, but again, the neuroretinal rim looks pretty okay. You see, there is so much of superior and inferior defect. For having such a superior defect, which is so close to fixation, you should have a gross thinning of the RNFL. You should have inferior rim loss. It's not there. So I trust my disc finding. There is a problem with the perimetry, and this is a very common problem, what we call as the learning curve. When we repeated the perimetry was normal. So for resident, I'm telling you, always evaluate disc properly, preferably with a 90D or a 78D. Do a stereoscopic evaluation. Make a picture of the disc in your mind or write it in your file. Okay, this is a 0.6 or 0.7 cupping. Where is the thinning? Whether the RNFL defect is there or not. Whether there is disc hemorrhage is there or not. And then you see the OCT or the HPL. Don't go in reverse. If you have created an image of the disc, then see the perimetry. If you see a thinning if you see the superior defect in perimetry, then you try to correlate with your disc finding. Always remember, 50% patient in their first or second perimetry do have a learning curve. So basically, the patient is not able to perform the test properly. Over time, when they will learn how to do the test, they will do a better perimetry. And all of you, I suggest you, mainly the resident, please do perimetry on yourself also. Then you will realize it's not a very easy test. It takes some time to understand and master. So what is the most important investigation in glaucoma? It is neither OCT, HRT or GDX. Most important thing is the stereoscopic disc evaluation. Have a learn proper evaluation of the disc. And the key for glaucoma diagnosis is the disc and the field should clinically correlate. So for example, if you have a disc like this, where there is a inferior thinning and there is a superior defect in the perimetry, this is a classical correlation. You don't need even an OCT to tell you that this patient is having glaucoma. This is a classical disc finding. So this was the basics of glaucoma evaluation, which I wanted to discuss. Since we started around 20-25 minutes late, Dr. Ajit, can we discuss a bit of OCT also?
I think
Yeah, sir, I think.
Manish, go ahead with OCT also.
Please.
But in the meanwhile, can you involve the residents also? Ask them questions also whether.
Sure. So I think you can just stop here once and we'll take a few questions. And then if the time permit, we will go to OCT. The basic idea of this presentation was to highlight about the common tests which we are doing in an OPD, like the AT, gonioscopy, disc evaluation, and perimetry. We have touched all the four, and we have touched about the CCT also. We have a lot of residents. I'm sure they all must be doing it. There are a lot of questions also. We can discuss a few of them.
We will take up one by one, Dr. Manish. I think
And we can also involve Sumita Madam and Shahinur.
Yeah. Ask question to the residents also by name. Otherwise, nobody will raise their hand.
Yeah.
So I'll ask to one. Dr. Preeti Gupta. Dr. Preeti, are you resident? Dr. Preeti, please switch on your camera.
PMCH.
PMCH. Dr. Preeti.
He is from Assam Medical College, I think, right?
Dr. Preeti, are you there? She has left. Dr. Sonali,
she is there.
Preeti Gupta is there. She is there. She is there.
Preeti,
yeah.
So Dr. Preeti, do you have any question? Tell us.
So, in glaucoma, we study that structural damage precedes functional damage. What are the diagnostic modality at grassroots level help patient to get a diagnosis earlier? FDT and SWAP are very hi-fi technology we are not doing in small town like Darbhanga.
So SWAP is almost obsolete, Dr. Preeti. No one is doing SWAP. FDT also is almost obsolete. No one is doing FDT except if you are doing a screening in some camp area, people can do so FDT. So as we were discussing, the most important thing in glaucoma are four things. One, what is the intraocular pressure? What is the gonioscopy?
Yes.
What is the disc finding? And CCT. These four basic things you should do in a glaucoma patient. And if you see that there are disc changes, then you should try to see the structural and functional test. So what is functional test? Perimetry is a functional test. Do the perimetry, see whether there is a field defect or not. But as I was telling you, when you see a field defect, always try to see whether it is matching with your disc or not. Similarly, when you're doing OCT, suppose you've done OCT and there are one or two red areas nasally, temporally, you see whether in a disc evaluation, those areas there is thinning or not. Because sometimes what happens, when you do OCT randomly, even in normal eyes, out of 100, 30% patient will have some red or yellow area. So you can't blindly trust even OCT or a HPF. Always correlate with your disc finding. This is all what is required for a glaucoma diagnosis.
I think Dr. Manish is rightly saying that we have to suspect the glaucoma first. I think, and then confirm on other tests. I think the newer test.
So suspect can be in IOP suspect, angle suspect, disc suspect. If the pressures are high on a routine evaluation, you will suspect there is glaucoma. You will do a detailed evaluation. If you're doing gonioscopy, you find the angle is closed or there is excessive pigmentation, or if you see there is angle recession, you will suspect a glaucoma. If you see the disc that there is a neuroretinal rim thinning, then you will suspect glaucoma and you will have further evaluation. One point again I was telling you about the comprehensive evaluation. See, patient will not always come and tell you ki Dr. Preeti glaucoma hai ki nahi, dekh lijiye. That is not happen. Na? Patient will come for itching. Patient will come for cataract. Patient will come for anything. Maybe patient will come for diabetic retinopathy screening. But if you are checking pressure in all your patients, you are doing a gonioscopy or at least a Von Erich, you are seeing a dilated disc, you will not miss glaucoma. So make sure you do a comprehensive evaluation for every patient.
Dr. Manish, from the panelist, how will you differentiate between a glaucomatous disc change and a neurological disc change? I mean, this is what probably Dr. Preeti was trying to ask.
Is it? Sumita, Madam, you will answer this question.
Yeah, Dr. Sumita Madam will add. Yeah, how to differentiate between a neurological disc appearance and a glaucomatous? This is what the Dr.
They want to know that, no, because we have to see disc as a whole. My main important thing is that only the cupping size of the cup is not very important, because neurological patient neurological cupping will also be there, but it will not be deep like the glaucomatous cupping. And neuroretinal rim healthy is a sign of glaucoma, can be sign, but in case of neurological deficit, it will be pallor is more important, and other things, other signs also, shallow cupping and all these things will give us a clue that it is a neurological cupping. And wedge defects we have to see better to see in the red free light. That will also give us a clear picture that it is a wedge defect is there and it is touching the disc, and that way also we can know that it is a glaucomatous cupping. Moreover, it has to be correlated, of course, but by seeing that thing, whether the cup is shallow, and we have to, particularly in the resident level, we have to mark where the vessels are actually bending, and what is that place is the actually depth of the cup. That everyone should be habituated in taking the where the vessel is bending. That is not depending upon only the color. That usually the mistake they make. They depend more on the color cupping than the contour cupping. Contour cupping is more important. It is the only important thing in case of glaucoma evaluation that they should not miss.
As ma'am has rightly pointed it out, Dr. Manish, that the color, the examination was more important than the field itself. So I think the clinical examination is of a paramount importance. I think there are many residents here, and Dr. Sonali Singh from Odisha, she also wants to ask one question. Dr. Sonali, are you there?
Yes, sir. Yes,
Please,
sir.
please, you have question for.
Sir, while evaluating the disc, why we take that vertical increase in the diameter, we consider it important?
Yeah, I think it's a very pertinent question, Dr. Manish.
Very good. I think I can ask Shainur also. Shainur is there. Shainur, you want to answer this? Why we take vertical and not horizontal?
Yeah, see, what is the normal contour of the cup, or how is the cup in a normal disc? We normally describe the disc as a vertically oval disc with a horizontally oval cupping. That is how the normal disc should be. So whenever the cup also becomes vertical, you have to give particular attention to the superior and the inferior rim area to look for any RNFL or wedge defect. Okay, so that is how, that becomes important.
So Manish, would you like to add something?
Basically, traditionally it has been seen that the glaucoma damage mostly starts in the poles, superior and inferior pole, because these are the area where the connective tissue is weaker and the concentration of nerve fibers are more. So that is why when the cupping mostly starts superior inferior pole. So that is why we always try to look into the superior inferior pole and look into the vertical cupping, because nasal and temporal damage occurs in the much later stage. So that is why when you're seeing cupping, you always try to see vertically. This is what Dr. Shainur has mentioned.
Dr. Nitin, you also want to add something, Dr. Nitin?
This is a very interesting question. Dr. Nitin is there? Dr. Nitin, I can't see him.
I can't see him. I can't see him. I think
very nice question by Dr. Neha. Why there is underestimation and overestimation of IOP in the rule and against the rule? This is very interesting question actually. Pranav sir, I know this happened, but why it's a very interesting question? Pranav sir?
Just let me see. What was the question?
Why there is overestimation of IOP with the rule and against the rule astigmatism in Goldman appellation tournament? Questions from residents are so difficult. We have to go back to.
I really don't have a clue. I mean, for astigmatism more than 3, you have to basically adjust the prism accordingly and then take the intraocular pressure. That much I understand, but why it happens, I don't have a clue to that.
There's no direct answer that even I have come across, but is it possible that because of the changed contour with the increased astigmatism or a different kind of astigmatism, the Meyer's width also changes? So is that a possibility that we underestimate or the IOP?
Definitely, I think, but for the basics of glaucoma, I think that amount of change, just wanted to highlight, should be not that much. Doctor.
But the question is, Ajay, why it happens? Does it happen or not? I mean, that is the question. Whether it is relevant or not.
Whether it's significant or not is not the question. The question was why.
Why that happens? So we'll have to read that. We'll have to do a research and then come back.
Very basic question. There is one more interesting question. One patient present with new vessel glaucoma and glaucomatous optic atrophy in one eye. Vision is PL absent, other eye is normal. How to approach that case? I think Dr. Somora. So basically, I can answer, Dr. Ajit?
Yeah.
So this patient is having no visual prognosis in one eye, other eye is normal. So what you should try to see that what is the cause of glaucoma. Suppose there is a retinal vein occlusion or a diabetic retinopathy, so that you have to ensure that the patient is systemically stable and that cause doesn't affect the other eye in future, so that you protect the other eye. So control your blood sugar, control your BP. Sometimes you can have ocular ischemia, so do a carotid Doppler to make sure it doesn't affect the other eye. Treatment wise, since there is no visual potential, PL is absent, you just control the intraocular pressure. Try to make sure that it's not a painful blind eye, it's a painless blind eye. So it will be more of a symptomatic treatment. If the patient is having pain and inflammation, you can give steroids, give anti-glaucoma medication, go for a diet cyclophotocoagulation or a cyclocryotherapy to control the pressure. If the patient is totally asymptomatic, even if 30-35 pressure, eye is quiet, you can just keep the patient on anti-glaucoma medication and tell the patient when there is a pain and all, then you will intervene. So basically symptomatic treatment if there is no visual prognosis. However, if the vision is good, say it has say 660 or 618 vision with neovascular glaucoma, then obviously the approach will be different. You will try to treat the cause, say do retinal therapy, laser or injections to control the ischemia, and then control your pressure with maximum medication. If you're not able to control with maximum medication, those cases you may consider going for a trabeculectomy or a glaucoma shunt surgery. So this is the way I think we'll approach. Anything else, Dr. Ajit, you would like to add?
It's rightly, Dr. Subhita ma'am is there, so she can also put that one at this stage. If the patient is painless and he just looking for the, we can just give him the symptomatic treatment. Nothing else to add at this moment, especially surgical and anything. Dr. Subhita ma'am.
Yeah, that's the thing. If it is not giving any trouble to the patient, then let him be such like that. And cost, we have to eliminate what is the cause. And if required, anti-VEGF injection and all that will regress the vascularization. Before surgery, it is better if you regress the vascularization, then you tab or anything, that is a better.
That patient has a visual potential, I think the question. Then it has a options, I think. Like 624 vision in one eye, and then we have to do something else. Dr. Manish?
Yeah, I think I'll agree to what Madam has said. So basically, if the vision is not there, so basically we have to give a symptomatic relief. There is one question by Dr. Dr. Ajit. Dr. Neha has also a very interesting question. That if the patient pressures are, if the disc is having significant field changes, can we start treatment without doing field? Because patients in OPD are poor and they have a tendency to loss to follow. So, Sumita madam, will you treat only on the disc, no perimetry? She has not mentioned the pressures also.
Yeah, pressure and moreover, perimetry for the first time also we can't rely on that because patient really have that learning effect. So, and another thing also we have to consider whether the patient is going to come back to us or not. If he is going for, and some patients we can know they are not going to come back to us. In that case, it's better to start treatment. Moreover, if there is having any family defect and any pseudoexfoliation and anything without even doing perimetry, we should start because we have to save the vision because pseudoexfoliation, they progress very fast and there is family history also, then patient is worrying and then we can start some treatment. And in our setup, it is the most difficult thing to convince the patient to come back to us, not that stay. That if we have any doubt, then we have to start minimum treatment.
How you take those patients basically who are not coming for a regular follow-up? What you say to your patient? I think it will be a question. It will help to get the compliance of that particular patient. Dr. Manish and Dr. Sainur first.
I didn't get your question. Can you just repeat once?
Those patients, glaucoma patients, who are not compliant in their treatment, they're not coming up for the regular follow-up, they're not putting up some medicine. And if they come to you off and on, what you say to your patient, like to increase the compliance, basically? Because the residents also face those questions.
Yes. So I at least advise them or repeatedly counsel them at least 2 to 3 times max. But after that, also, if they are, I mean, on the third visit or second visit, at least I will tell them that if you continue this way without applying the anti-glaucoma medication, then you will end up requiring surgery. That will be the only option left for you, and the disease will also worsen. You will progressively become blind. So that is what I tell them. And by the time, if they continue it for another 2-3 times, by third time I definitely advise them surgery, whether they go for it or not, but I definitely advise them surgery.
Definitely. So you, Dr. Manish?
I will agree to what Dr. Sainu said, but my approach is also similar. I always try to counsel the patient myself. I'll give them some booklet to read. We have prepared some short 2-3 pages booklet. I'll ask them to read and sit in the OPD and come back and ask questions if they have. But some patients are very casual. They are not compliant. So those patients, I like to scare them. Mostly I don't do it. I am very positive with the patients because anyway, life is difficult for all of us. Why to make it more difficult for them? But those patients, I really scare them. I will tell them it will become so difficult. How will you go to washroom? Just imagine people are feeding you. You can't see your granddaughter or grandson. So then they get that realization. So those patients, definitely I scare them. And I also document in the file that patient is non-compliant, patient may require TRAP, because from medical legally point also, sometimes when they become blind, there is always a tendency to blame the doctor. I was in your treatment, I became blind, your mistake. Never patient will come and tell you I was not using medicine or I was smoking 20 cigarettes in a day, so I lost my vision. They will always say I was in your treatment and I became blind. So you should document in the file that patient is non-compliant. I've also seen sometimes involving family members is a good idea. Suppose the wife or a spouse or daughter, mainly I think daughters are better than sons. So if there are daughter, I involve them. And I tell them very sympathetically, look, the father is going blind. It is your responsibility to ensure. I've seen they take extra care. So involving the family is useful at times. They will ensure that the patient uses the medicine more regularly.
It's better to scare the family members. If you tell them if he goes blind, then you have to put an extra care and extra effort, extra time, everything. That will scare them and they will bring them regularly. Usually the attendants do not bring the patients to us. And we have to have, the key is to have some extra time for them. They require some extra time. And
but one point for resident, don't scare every patient. Scare patients who are really non-compliant, because you will see so many patients crying in your OPD who may be having ocular hypertension, not even having glaucoma. So don't scare everyone. And this question regarding what Dr. Neha was asking about whether to treat purely on the disc and not doing perimetry. So as Madam was mentioning, suppose the pressure is high, say 25, 26 or 30, whatever, and you see the disc finding are there, you start the treatment. But you have to do investigation also. You have to do a perimetry, have to do a CCT and a disc photograph at least. See, perimetry patient may not be able to do it properly, but if you can take a disc photograph showing that there is an inferior loss or there is a RNFL defect or a wedge shape defect, the documentation is also important. You can't just purely treat based on a disc finding. Whether the patient is doing the test or not, or future following up or not, but have a habit to write the investigation, because as I was discussing with you, that perimetry or a visual field defect is a part of definition of glaucoma. So you can't deny that patient. You have to write a field. Don't make it a habit to start treating only based on IOP and disc.
Absolutely right.
Definitely. And the very important fact which has come up is the documentation. I think documentation of each and every finding and with the current medication is of paramount importance. Dr. Manish says, even the compliance, you have already told that one. And based on this perimetry, you cannot say that's without, even in OPD, many residents come. I'm just giving an example, and they come with a with a all plain paper and then with a field and OCT and say that it's a glaucoma or not. Manish has already pointed it out. There is one question coming. Is it necessary to add neuroprotection drug, brimonidine, along with PG analogs, as IOP is one of the risk factors?
Not the only.
One of the risk factor only.
Where is the question? Okay. So actually, in true sense, there is no proven neuroprotective drug in glaucoma. The closest we have is probably brimonidine, but that is also not totally proven in human trials. So currently, whenever we are treating glaucoma, we are actually treating intraocular pressure. So the best drug is the prostaglandin analog. If prostaglandin is not giving you adequate IOP control, you want additional IOP control, you can add a beta blocker or a brimonidine or a carbonic anhydrase inhibitor. There are multiple studies which have shown that all three are almost equally effective as an adjunct to prostaglandin. Brimonidine as a neuroprotector, I'll say still controversial, like a dorzolamide used purely as a vascular protector is also controversial. If you have a patient who is progressing, pressures are perfectly normal, but you see some disc hemorrhages, you can assume that there is some vascular problem going on. Those patients, you can prefer a carbonic anhydrase inhibitor over a beta blocker or a brimonidine. On the same time, if you have a patient who is progressing on prostaglandin analog, no vascular features, pressures are also normal, you can add a brimonidine. But as I was telling you, these things are not totally proven. We still are actually treating intraocular pressure only.
So from definitely from Assam Medical College, Dr. Markande Singh is here. Is there any question, Dr. Markande?
Thank you very much, sir. There is a simple basic question that I would like to ask sir over here. Sir told about having the clinical suspicion for glaucoma. The thing is, when we are treating around 150 to 170 patients in the OPD every day, it sometimes becomes very difficult to examine each and every patient in that manner. So I just wanted to know from such an esteemed surgeon that how to develop that clinical acumen to isolate patients who might be having glaucoma.
Dr. Sainur?
I'll just add 2 points.
I think
must do a slit lamp examination to see the status of the anterior chamber, number 1, and number 2, a disc evaluation and an intraocular. These are the 3 basic things that every patient, no matter how many patients you see, this is mandatory, these 3 things. And apart from that, the addition like fields and other things, they come subsequently.
Okay, thank you.
What you say that in a busy OPD with 150 to 170 patients, obviously you are not examining all the patients yourself. There are others also. So that you don't miss out on anything, you can systematize your OPD. That some of you can be involved in doing the slit lamp examination properly. Somebody with the slit lamp IOP, disc exam, you just divide it. That way you complete all the examination for all the patients that is necessary. When we talk about comprehensive examination, it has to be done. There's no other way you can, pick up without doing this basic examination like slit lamp, IOP, and disc examination. I'm not even mentioning gonio. You cannot pick up glaucoma suspects. So these are very, very necessary.
Okay.
It's a very common has pointed it out. I think division of work in a OPD is also one factor, and also if you are doing a good examination, over especially dilated examination. I say if you are doing a dilated examination, you will not miss a glaucoma diagnosis, and it's quite easy nowadays, even with the indirect as well as the slit lamp.
Especially, I think in a medical college, if you're working in a medical college, like I think Dr. Makande, I think is there from the Assam Medical College.
Yes.
So at least the basic thing, if you do a slit lamp examination, at least you can't do a gonioscopy also. If you can, like Dr. Manish has already highlighted, the Van Herrick test, please you do that. And those who are suspicious, at least a disc examination. and the intraocular pressure. I think this is mandatory, and those who suspect any little bit of amount of suspicion, then I think you can go for dilated and gonioscopy and other detailed examination.
Okay, thank you, sir.
Manish,
So you have no excuse to say, since you are in the tertiary medical care, and then you can't see enough patients, 150 patients or 200 patients, whatever it is.
Dr. Manish, somebody asked me, just tell me one examination which can raise the suspicion for glaucoma. I said only disc evaluation. One examination.
Yes, right. This is the most important evaluation. And the infrastructure is the problem, but as Dr. Shainu was mentioning, we have to divide the work and we have to improve the infrastructure. India has 1/5 of the world glaucoma population, so we have to have more trained ophthalmologists to tackle glaucoma. But not doing a disc evaluation and leaving a patient, not checking pressure and leaving the patient, will end up in a serious trouble over a long time.
And what gonioscope do you suggest for the residents to start off with?
We always used to initially say that we should start with a 1 mirror, 2 mirror gonioscope, because there the fixation is better. You see the structures properly. Once you are confident of the structure, then slowly move to a 4 mirror gonioscope where you can do indentation also. But I think in Shankar Netralaya and even LVP probably they start straight away with a 4 mirror only. So that also can be tried. Initially, there will be some learning curve in everything. So, but slowly over time, you will master it. And for resident, I can tell you, nowadays there are a lot of very good websites. Like there is a gonioscopy.org website. Just go there, you will see variety of pictures. They will train you how to do gonioscopy. You can download those images on your phone and your tab. And when you're seeing patient, every day do 4 or 5 gonioscopies. Maybe at the end of the OPD, keep some patient, do 4 or 5 gonioscopy every day. Over a period of 1 month, you see you have already done more than 100 gonioscope, and you will be comfortable holding the gonioscope, seeing the structure. So if you can do a cataract surgery in a topical anesthesia, why can't you do gonioscopy? This is like a cakewalk for all of you.
Exactly. And start on a myopic patient, you see all the structures. True. So I started gonioscopy on a suspend indentation gonioscope, the 4 mirror one. That gives a very good picture of the angles.
Even the Indian company gonioscope is also very good.
Coupling fluid also.
Yeah. Even the Indian ones are also very good. If the cost is a factor, they're also pretty good. 4,000-5,000. We also use it in our OPD, both the Indian one and the walk and the ocular. They're pretty good. You can use them also.
Swami Roy from Odisha has one question. I think she is asking about nasalization of disc vessels. Dr. Swami, are you there?
So in between, all the residents should have a gonioscope of their own in their pocket all the time.
The question was from Dr. Swami Roy, and a little bit interesting from the resident points of view, why there is nasalization of disc. Especially, I think he is talking about advanced glaucoma.
Similar to the question which we had previously about why superior inferior damage occurs. So these nerve fibers have a connecting tissue also. As the glaucoma increases, the damage occurs first inferiorly, then superiorly. This is the normal pattern what we see. These are the area where the soft tissue damage occurs. The nasal soft tissue are involved later. So that is why the vessels initially move toward the nasal area, because this is the last to be involved. So this is the way why we see the vessels moving nasally in advanced glaucoma, because of the tissue loss, soft tissue loss in the
But I think any other question from any of our residents present here? One question from my side, I think regarding basics of glaucoma, as Pranav sir has already told that the disc diagnostic.
If you don't have anything else, just one thing to bank upon. What is the most important? This is, but other things are all equally important. Yeah, of course.
Massive. Without a disc screening, you cannot classify a glaucoma. And Dr. Manish has already said, classify glaucoma on your paper, on your medicine, on prescription, and then you will come to know about this importance of this test, the documentations of everything. I think over to sir for such a. I think there's one new message is coming up. Okay, so from Swami Rai itself. So over to sir for the latter part of the this session, and I was really get acknowledged as again with Dr. Manish having so much emphatic knowledge of basics of glaucoma and giving importance to the clinical examination. I think which is of paramount importance. So over to you, sir.
Thank you, sir. I think Dr. Sabasati is there. Are you there?
Yes, I am here. Sorry for not being. I have a problem with my video.
Request for concluding the remarks from you.
No, thank you very much. Thank you, Singsui, for arranging this nice program.
Can you please proceed with the...
No, I have a problem with my video, so I'm not coming with video. So just excuse me for that. But this is a nice program, as Ajit has rightly said at the beginning, that every time there is a new thing to be learned from Manish. So all of us, I think we have learned something new today by attending to this program. And I think residents are also being quite benefited from his teachings, the basic 4 things that he emphasized for assessing and starting treatment and labeling a person as a glaucoma and starting treatment. You have to follow those 4 things. That is actually most important, because once you brand somebody as a glaucoma patient, it's really a traumatic experience for him if he understands what is glaucoma and what it is going to lead to. So I thank Dr. Manish very much for this nice explanation of all these points and why it is essential for the residents also to understand from the beginning of their career, so that that will help them to deal with glaucoma patients in a better way. Thank you very much. Thank you, Pranab sir, our President EIZOC, for initiating and for taking so much of interest in having this ARC program of EIZOC. And Dr. Singsui has rightly also carried forward the program. And I thank Dr. Ajit for nicely moderating this session. Dr. Sainur and Dr. Sumita Madam also, as a panelist, they have done their excellent job of summarizing things and giving their valuable expert opinions. So thank you all. Thank you very much.
Okay. Thank you so much, Dr. Sarvasasi. I think you have proposed the vote of thanks already on my behalf.
The final word has to come from the chairman ARC, sir.
Okay, yes, sir. Yes. Okay, sir. It's coming. On behalf of the ARC EIZOC, our wonderful, special thanks to Dr. Manish for the wonderful rendition that you have given on this topic and putting the right perspective for the basic diagnostic skills and then how to do about it. It has been really wonderful. I think not only the residents, I think it also really put on so many things for the seasoned ophthalmologists like us. I also would like to thank on behalf of the ARC, our moderator, Dr. Ajit Kumar Dwivedi, for an excellent moderation. Thank you so much, sir. We'd also like to thank the distinguished list of panelists, Dr. Sumitra, Professor Sumita Mahapatra ma'am, Dr. Sahinur, and Nitin. I think he is somehow not there, but for the superb and enriching contribution from each one of you. Thank you so much from the ARC EIZOC. And of course, we want to thank also the residents who have been really active. I hope you have really benefited from this. Dr. Neha Kumar, Dr. Kumari, Dr. Preeti Gupta from Darbhanga Medical College, Dr. Anvisa Banerjee and Markande from AMC Dibrugarh, Dr. Sonali Singh and Soumi Roy from Bimsar, Odisha. Thank you so much for your participation and making this webinar very lively. I'd like to also thank all the members of the ARC from the different states for their for participation. And again, on behalf of the ARC, would like to thank the President, Dr. Pranab Ranjan sir, and the President-elect, Dr. Jayant Barua sir, for gracing this webinar and making this so resourceful and making it very, very lively, and for your unfaltering support. To the Secretary, Dr. Swaras Bhattacharya, and Joint Secretary, Dr. Lobsang, for a dedicated support and showing, support every time that we ask. You have been there always. I'd like to thank our Chairman Scientific Committee, Dr. Sabyasachi Patnaik, for this lucid and comments that you met at the end. And I'd like to thank, on behalf of ARC, all the audiences that have met this webinar really, very, really good. And last but not the least, I'd like to thank Anthod Pharma for making this this program successful and possible. Thank you so much, sir. Thank you so much, all. Thank you so much.
Thank you very much.
Thank you, everyone. Thank you so much.
Thank you.
Expecting so many nice programs in future from you, sir.
Yeah. Yes, and the recording is going to be parked in the YouTube. So anybody who wants to listen, we'll put it in the various groups of EIZOC, and also place it in the YouTube also, so that anybody who has missed the program can watch it later on also.
Looking forward to much more such webinars in the future, sir. Thank you so much.
I mean, it all depends on you. We are all banking on you, and we are pretty sure you're going to carry.
The other just before the beginning of the seminar, Dr. Subudhi sir called me, and then he was talking about this thing. So I I told him already. He said we'll be sorting it out with the president and
it has been sorted out. Weeks have been allotted to ARC, to ORTS, and the Voice of East. They are going to be in separate groups. They are not. There's not going to be any class from February onwards.
Yes.
And both our ARC program are excellent.
Yeah, and thank you, Manish.
Thank you once again, Dr. Manish.
Manish,
Madam Saino, Madam Sumita.
Yeah.
And
thank you.
Thank you so much. Thank you so much for your excellent rendition. Thank you so much.
Good night, sir.
Good night.
Good night. Manish, इतना आदमी के सामने बोल रहे हैं कि we are going to bid for the GSI annual conference बिहार के लिए. And we need your support. Ajit Dwivedi है, कहाँ चला गया?
This time Assam will also support you.
Last time we lost out because it was the first time. Now we have the midterm conference at our back, that we had a successful AIOS midterm conference. So with that backing, we'll go forward with and we need all your support and everyone's support from the EIZOC.
Manish has a special affection for Bihar. Even an EIZOC, I'm saying.
Manish हमको बोला था कि sir, this is the first time Kerala में हो रहा था. He told me कि first time sir नहीं होगा sir. Nothing is going to happen. Next time we'll see. Next time has come.
I'm sure sir. सुमिता मैडम है, शाहिनूर है, तो कलकत्ता, ओडिशा और असम का तो सपोर्ट हो ही गया. बस आप आगे बढ़ जाइए सर.
हम तुमको नहीं
अरे पढ़ो बॉस,
हम बिहार में आने नहीं देंगे उसके बाद. नहीं,
अरे पढ़ो बॉस, आपके रहते बिहार आ जाएगा. पढ़ो बॉस, चिंता मत कीजिए, हम है ना.
आ गया मेरा ये आ गया, जेम्स बॉन्ड आ गया, डॉक्टर मिलिक. रिकॉर्ड में नहीं जाना चाहिए भाई, रिकॉर्ड बंद कर दो. राहुल,
Stop the recording.